We are Össur Academy, bringing you virtual learning direct to your desktop or mobile device, wherever you are and whenever you need it. We believe in the value of appropriate and relevant clinical education and have a wide range of learning formats specifically for you. Whether this is for your own CPD, product insight and awareness, or detailed training relevant to your own clinical needs, we provide a huge range of remote learning opportunities specifically tailored to you. We bring together key opinion leaders sharing insights into orthopaedic and prosthetic clinical pathways, our own clinical and professional sales teams offering you detailed product insight and evidence-based education, large-scale secure webinars professionally managed with multimedia content, virtual fittings and user demonstrations offering remote interactive support to colleagues and customers in their own workplace, pre-requested one-to-one virtual meetings with our clinical teams providing real-time diagnostics and support, open meetings allowing for multi-site interaction and knowledge sharing. Contact us now to arrange your own virtual training and education meeting, and visit our website to browse our back catalogue of webinars and other online education events. We are Össur Academy, providing your educational needs.
Hi, good evening and welcome to the 18th KOL of 2020, coming live this evening as always from our Manchester office. A bit of an apology if you had some audio issues at the start. Hopefully that's all been rectified now. So thank you for joining us this evening. I do hope you're all safe and well out there. Over the past 7 months, Össur have delivered educational content virtually, and it's great to see that it's still of interest out there, with over 400 people joining us this evening from around the UK. So great that we are joined this evening by Mr. Nick Nicolaou. If we can go over to Nick in Sheffield and say hi.
Hi, everyone.
Hi, Nick. Thank you for joining us. Mr. Nicolaou is one of the leaders in the field of orthopaedic paediatric care, and tonight he'll present on the paediatric knee, specifically on the area of patellofemoral. He will break this evening down into 3 presentations, focusing on assessment of patellofemoral instability in children, first-time patellar dislocation, surgery or non-operative management, and the surgical management of recurrent instabilities in the paediatric age group. So as we always do, I'm just going to go through a couple of housekeeping if you're not familiar with the Zoom format, but I'm sure over the last 7 months with Zoom parties, etc. at the weekend, I'm sure you all know how to use it. But we like to make these sessions as interactive as possible, and Mr. Nicolaou will be taking us through 3 12-minute presentations. So if you do have any questions, please do put them in the Q&A function, and my colleague Giles Lehman will be manning that this evening and asking Nick those questions to him directly. If you do have any other questions in terms of chat, and there'll also be the link to next week's webinar at the end on the chat function, so you can put stuff in there. As always, the session is recorded and will be put on the Össur Academy YouTube channel and also the Össur Academy UK site to be viewed at a later stage. And for your attendance this evening, you will receive an e-certificate, as always, usually between 24 to 48 hours after this evening. That also includes a follow-up questionnaire, so if you can please do take time to fill them out. You don't win any prizes for it, but it does give us an idea in terms of content that you would like to see, but also how we can improve the webinar format. So before I pass over to Nick, we just want to do a quick poll just to find out who's out there in the audience this evening. So if we pop that poll up, and if you can answer, what is your role? So are you a doctor, consultant or registrar, orthotist, physiotherapist, occupational therapist, sports therapist, or are you an other profession? So usually leave that up for 10 or 15 seconds. It just gives Nick an idea of who is in the audience this evening. So I think we're up to 80%, so we can share those results. And in the room tonight, we have 16% doctor, consultant, or registrar, so 32. Orthotist, 12%. Physiotherapist, as always, the large bulk of the evening's audience at 61%. And then we have 10% of other. So thank you for filling that out. It's helpful for our speaker this evening. So before I pass over to Nick, just to introduce him, Nick is a consultant paediatric orthopaedic surgeon at the Sheffield Children's Hospital. He trained on the South-East Thames Orthopaedic Circuit and completed fellowship training at Sheffield Children's, Royal National Orthopaedic Hospital and also Great Ormond Street Hospital, as well as completing a travelling fellowship at Berne prior to becoming a consultant in 2010. His clinical interest is the paediatric knee, and he treats the whole spectrum of pathology from cruciate and meniscal injuries to congenital ligament deficiency and complex patellofemoral problems. He also maintains a clinical interest in the management of osteogenesis imperfecta and clinical research. He is the chair of the recent BASK steering committee on soft tissue knee pathology in children, which aims to improve national standards of care, and is also a board member of BOSTAA. So we're very lucky to have Mr. Nicolaou speaking for us this evening. And to get things going, I'll pass over to Nick. Enjoy the session, and over to you, Nick.
Thank you very much. Welcome, everybody. And we're going to start off by talking about the assessment of patellofemoral instability in children. So I will take you through what you need to pick up in children, what imaging and what measurements help you, and why these things are important, because this is what's going to allow you to decide on exactly what you're going to do in terms of management. And it's important to remember that patellofemoral instability is a spectrum of a disorder, and it starts off on the spectrum to the left towards traumatic dislocation and all the way up towards congenital dislocation. And as a result, the treatment increases with complexity as you go along that scale. So for me, clinical assessment is probably the most useful tool in deciding on your management. And that's made up, as we all know, of the history, the examination of the patient, which you can divide into local factors, those things relating to the structure of the knee itself, to limb factors, which is more to do with alignment in the coronal, sagittal and rotational plane, and also general factors. So when you start off with the history, the key questions that you need to be asking are, is this the first episode, or have they been recurrent episodes? Is it ipsilateral or is it bilateral? How much trauma did the knee come out? Did it dislocate when, for example, playing contact sports or just getting up from a chair? For me, family history is very important. And that implies someone that may end up going down the surgical management route. And we know that genetics plays an important part in the development of the trochlea. If you look at studies in utero, the trochlea is already there despite the fact that no forces have gone through it yet. And we also have big differences in the way the VMO inserts between different individuals. Often kids will have presented with leg pains or been described as having growing pains as a child. And bear in mind that breach is a risk factor for trochlear dysplasia, which then predisposes to dislocation. General factors include things like syndromic diagnoses, such as Down syndrome, which this X-ray below shows you. We also use the Baton score to classify hypermobility, bearing in mind that Baton's original classification was validated for a white South African rural population, and it's never been validated in kids. But a score of over 4 is usually taken to imply that there's hypermobility. Then you look at factors related to the whole limb. The presence of flat feet is a problem because it increases the valgus angle of the knee, as does having genu valgum or knock knee. The easiest way to assess this clinically is to ask the patient to stand feet pointing forward, bring the thighs together till they touch, and measure the distance between the malleoli. As a rough rule of thumb, 8 centimetres at age 10 years is outside of 2 standard deviations and abnormal as a clinical assessment. Genu recurvatum is another feature you should look for, as is the torsional assessment, and look for muscle wasting or weakness, particularly proximally. This video is showing you a girl that has patella alta and a torsional problem, and you can appreciate that with the gait, but not as clearly as you would do with formally assessing the actual rotational profile. But gait gives you a little bit of an idea about core stability, weakness around the hip, and also you need to assess for calf tightness and hamstring tightness, which often coexist. And these are things that can be helped by the input of therapy. Now, in terms of coronal malalignment, so knock knees cause problems with patellar instability because basically it increases the lateral displacement force on the patella. And we've got to remember that normally the Q angle is a little bit different. We all have a small degree of valgus, but having genu valgum causes fatigue. So often kids with this as an isolated problems will complain of leg pain, reduced exercise tolerance. We don't think at present, or we don't understand if it definitely leads to osteoarthritis. But if someone has this problem, you can treat it with guided growth. And some surgeons would do this at the same time as reconstruction if surgery is indicated, although I prefer to correct first because it will change the tension in the MPFL reconstruction itself. And we may get to the point where we're able to use guided growth to actually correct rotation, and that's something we'll keep an eye out for. But how much of a problem is this malalignment for instability? Well, if you look carefully in the literature, you'll find studies where you can see the contribution. Example is the left to your screen from Vince Mosca in San Diego, who looked at 26 knees in an average 12-year-old cohort of patients who all had patellar instability and were treated just with guided growth. 69% got resolution of their patellar instability. The remainder improved in terms of symptoms. The study to your right comes from Dallas in Texas. Here they performed isolated distal femoral osteotomy for people with recurrent instability. It's a small cohort of 11 patients with 4-year follow-up, but 80% had no further instability, having dealt with that problem with the alignment, which tells you the importance of it. So here we can see a therapist is looking at the transmalleolar axis to identify abnormality or external tibial torsion, and the picture to your right shows you assessing the rotation of the hip, and it's important to assess how much internal as well as external rotation, particularly if it's something that you think you need to treat. In terms of the local structures of the knee, we must remember that there are lots of factors that will influence instability, and those include the soft tissue, static and dynamic structures, and all those ligaments of the knee, as well as the PCL. You can also assess the lateralization of the extensor mechanism, which we'll discuss later in another talk, as well as the patellar height, and get an idea if there is a problem with the patellar anatomy or the anatomy of the trochlea. So in assessing patellar stability, you need to assess how many quadrants it displaces by in extension, and then up to 30 degrees of flexion, and then in deep flexion, which is also important. We know that patients that can have apprehension that's positive beyond 60 degrees of flexion will do badly with an isolated MPFL reconstruction. Apprehension, as well as looking for apprehension, look for an effusion in the knee. That will imply there may be a chondral injury. Look for clinical patellar tilt, which you can appreciate, and for any possible positive sign in terms of a patellar grind test. Although that's a non-specific test, it may tell you there is some chondral damage, which can again influence your treatment. Now, we talked about the J sign. Well, we haven't talked about the J sign. We're about to now. The J sign basically is where the patella sits in extension, lateralized, and as you flex the knee, it engages in the trochlea. This is an important sign because having an isolated J sign, which you then treat with an MPFL, is associated with a higher rate of failure. So once you've done your clinical assessment, you're going to move on to imaging. And what imaging should you do? You've got a choice between plain X-ray, CT, which can be done static, or dynamic investigations, such as shown to the right, or MRI. When you're looking at plain X-rays, first of all, you can appreciate problems with the size or shape of the patella, if there are any trochlear spurs that may imply trochlear dysplasia. But you can also measure ratios of patellar height. Here we've seen the modified Inselspital index demonstrated, which is just a ratio of the length of the patella and the patellar tendon. If this is high, it implies patella alta. There are other indices such as the Blackburn peel. Caton de Charme is very popular in Europe and tends to be used there more than here in the UK. But for me, the mainstay of investigation is MRI, and MRI is very good at looking at particular things as well as anatomy. And we'll go through some of these. Here's just some pictures of MRIs. Top left, you can see patella tilt. Top center, you can see an osteochondral defect as well as an effusion. Top right and bottom right, there's bone bruising in the lateral femoral condyle, which arises after an acute dislocation where there's an impaction injury of the patella over the lateral condyle. More subtle signs, the bottom left, you can see edema in the fat pad, and the bottom center, evidence of MPFL injury. But with MRI, you can also ascertain the patellar height, and there is this index called the patellotrochlear index described by BDER, which is basically a ratio that you look at on the MRI. Now, why the MRI is why it's useful is when you do an MRI of the knee, there's a much better standardized position of the knee held in full extension, as opposed to trying to get a lateral X-ray, which sometimes is very difficult to get at 30 degrees and therefore gives you an error in measurement. And the way that you measure this ratio is the longest part of the patella, where the patellar cartilage is thickest on the sagittal sequence. You should see overlap of more than 10% with the trochlea. This is a case of a failed MPFL reconstruction where you can see there is no overlap at all of the cartilage. The next measurement is the TTG. But what is this measurement? Well, it's basically a measure of the lateralization or some degree of rotation that occurs between the trochlea and the insertion of the patellar tendon on the tibial tubercle. This is a very useful measure. You can do this measurement either on MRI or on CT scans, but do be aware there are different values because MRI gives you a lower figure than CT by about 2 to 3 millimeters because it goes more on cartilaginous measurements. Bear in mind also it's difficult to take this measure if there's severe trochlear dysplasia. And the reason for that is the way that you identify your points to measure this distance. So basically you go down the axial scans till you find the first slice where the trochlea is covered by cartilage. The perpendicular line across the posterior condylar axis forms your first point, and you can see on this picture it measured on the CT to the right. You then go down to the first slice where the patellar tendon covers the tibial tuberosity, and the center point of that, you draw that parallel to, and superimpose it on the other image, and that distance is what your TTG is. Figure of 20 millimeters or more is quoted as abnormal. Here you can see how you get that measurement from superimposing those two images from either the CT or the MRI. There is also another measurement called the TT-PCL, and this measurement's more popular amongst adult surgeons, which references the PCL insertion on the tibia with the same point on the tibia that you use for the TTTG. This is thought to be better because it avoids you don't have to identify the deepest part of the trochlea where there's trochlear dysplasia. And here you can see the measurements that you take in order to get this. But when people have looked at this measurement in children, the figure of greater than 24 is thought to be abnormal. Kids have a much lower figure that changes with age, number one. And number two, also, when they looked at a cohort of patients with stability, normal stability and instability, there was no real correspondence there, which probably tells us that the TTG is measuring something a little bit more specific by referencing from the trochlea, because we know that it's higher in children with instability. We also know that it gets bigger as you grow, and it changes also with the degree of knee flexion. Here we can see a chart from a publication that reports that TTG changes with growth. So you can see continues to increase from a young age up to late adolescence. So for me, the values are different simply because they're measuring probably two slightly different things. And so the TTG is what you should use in decision making. So in summary, we've gone through history, examination, and how imaging will help you determine treatment. And all these things are important because that will then tell you how you're going to treat your patient and what's the best way that you're going to do that to avoid failure. Thank you.
Okay, thank you very much, Nick. One of the questions, any other questions that anyone has, please pop them in the Q&A. But it's just asking why do some consultants choose to treat Össur with a cast, for example? What's your normal treatment protocol for this?
I don't know who treats Össur in the cast. I have done it years and years ago, and sometimes it's just to break the cycle of pain, and it's a very variable condition. So in some children, Össur will be self-limiting, but you can see some cases where it's the recalcitrant, the pain, and sometimes it almost develops into a chronic problem. So the theory, I suppose, for cast management is that it gives a period of rest. The problem with cast immobilization is you're going to weaken everything. You're going to weaken the core. You're going to weaken the quads, and so in some ways, you can use it very, very selectively for certain cases where there's other conditions or other overlap. But for me, Össur is not something that a cast immobilization is going to be very helpful with.
Okay, fantastic, thank you. So we can perhaps move on to the next session, if you're ready.
Okay, so next we're going to move on to first-time patellar dislocation, whether we should treat these operatively or non-operatively. So I'm going to talk a little bit about if surgery for first-time patellar dislocation actually reduces the late onset of arthritis. And in children, are outcomes of non-operative versus operative management better? We'll also mention a little bit about how you should manage OCDs with first-time dislocations and talk a bit about the role of therapy and return to activity after these injuries. So I'm going to start with a few statements and be controversial. And I'm going to say that recurrent instability, especially those with risk factors, some of which we've talked about already, cannot successfully be treated non-operatively. But that first-time dislocation, in my personal opinion, should in nearly all cases be treated without surgery. And I'll tell you that evidence exists for both forms of treatment for first-time dislocations, but there are very few studies that compare them directly. That kids who sustain a first-time dislocation have a risk of greater than 50% of recurrent episodes. and that regardless of treatment, only 2 out of 3 will return to their pre-injury levels of activity. So that gives you an idea of the scale of the problem. And a lot of the theory about patellofemoral instability and how it should be managed non-operatively comes back to this paper from 1976 by famous surgeon John Inselspital, who looked at the results of surgery at 8 and 16 years in a cohort of patients managed with surgery and those without. And what he identified was that patients who did have recurrent instability with time got less of a problem and didn't develop arthritis, whereas those who underwent surgery had higher levels of arthritis with much shorter follow-up. But as all things, the devil's in the detail here. If you look at his cohort of patients, about 35 of the 40 knees had some form of cartilage abnormality, osteochondral damage. 6 of the surgical patients actually had a patellectomy, which we know is a disastrous thing to do for function. And 5 of the 27 patients had a growth arrest, and there were other numerous complications here. And the comparative group treated non-operatively were either the opposite knees, or there were patients who declined surgery or were advised against it. And if you look carefully at the surgical patients, if you look at the table in the bottom left, we can see most of the surgical procedures were what we call a Össur, which is no longer done, but this used to posterior medialize the tibial tubercle. And that, we know, increases loading forces and causes arthritis. A bit more careful thought shows you that the patients that had isolated, very dated soft tissue procedures actually did okay, although the numbers are small. So there may be some truth in this, but basically what it tells us is bad surgery is worse than no surgery. There's a very good population-based analysis looking at lateral patellar dislocation and osteoarthritis. If you look at the graph to the top right, bearing in mind this is a comparison with controls who are matched in terms of age, with 600 patients who've had a first-time dislocation, and you can see that patellofemoral arthritis increases rapidly from about 15 years onwards. And the bottom right shows you what we call odds ratios. So basically, the further over to the right, the more likely it is to cause you arthritis. And you can see here the main problem that leads to osteoarthritis after patellar dislocation is the presence of osteochondral injury. So what about skeletally immature patients? Now, that same study that I've just shown you, they looked at data for 232 kids with an average age of 14, but with very good long-term follow-up. What this showed us was that the recurrent instability was more likely in patients who had trochlear dysplasia and an abnormal TTTG, but the only thing that was associated with arthritis was actually the presence of osteochondral injury at the time of first dislocation. So in addition to that, it tells us that contralateral dislocation is common, and about half of the patients will go on to have recurrent instability after a first-time dislocation in this age group. So if we look further at what factors predispose to recurrence, just look at the graph to the right. The purple line shows you that these patients are having more problems with recurrence of instability, and those are the younger cohort patients who have trochlear dysplasia. This graph shows you that trochlear dysplasia in isolation is pretty much as bad as if you've got that together with patellar ulcer as well. So those are the two main things that really risk there being problems. And there's been a recent meta-analysis from the group in Melbourne who have identified that the things that predispose you to have a recurrent dislocation are being of a young age, having open growth plates, an increased TTTG, trochlear dysplasia, and patellar ulcer. And from our own experience at Sheffield Children's, when we've looked back at our patellofemoral instabilities, obesity also plays a big part. So we've mentioned osteochondral injury after first-time patellar dislocation. A nice study here, published some time ago now, looked at patients with a first-time dislocation. And when they look at these in a bit more detail, probably up to 40% of patients will have displaced loose fragments as a result of a first-time patellar dislocation. So we have to really look at this. Where do these fragments come from? They tend to be located in the patella, but also in the lateral femur, which is why you see that lateral bone bruising on the MRI in the earlier presentation. Also, patients that have lateral femoral condyle defects have poorer functional outcomes in comparison to where they're isolated in the patella. But bear in mind, MRI doesn't pick up all chondral injuries, as anyone who does arthroscopy in patients with recurrent instability will tell you. And when you see fragments that occur on the medial side of the patella, people often think this is the avulsion of the MPFL, but bear in mind that most of these are distal, and this actually represents the more distal constraints to lateral translation of the patella, the MPTL and the MPML. So what we can conclude about arthritis for patellofemoral instability is that redislocation rates are much higher in the younger age group, particularly with open growth plates. Return to activity is not guaranteed. Presence of osteochondral injury at the time of dislocation or repeated dislocations is the thing that leads to arthritis, and surgery may possibly predispose to this. We're not sure about that yet, certainly with the contemporary techniques we're using now. Having underlying joint problems, in particular those things we've listed at the bottom, patella alta and increased TTG or trochlear dysplasia, are the things that will lead more cases to recurrent instability. If we try now to look particularly at children and comparisons, studies that have level 1 or level 2 and above that have looked at non-operative management with first-time dislocations versus surgery, there's only very limited articles. The study to the left by Paedlafoemoral et al., which is a long-term follow-up comparing non-operative treatment with medial stabilization, didn't find a difference. Other studies have found a difference, but the study we're looking at to the far right, where you can see the redislocation rate was much higher in the non-operative group, it was only 38 patients. So if we move to more contemporary literature, a study from Karolinska Institute compared MPFL reconstruction versus management and rehab with a brace, including physiotherapy input. These are patients who didn't have an osteochondral injury, those were excluded, and just first-time dislocations, but all had an MRI and an arthroscopy within 2 weeks of injury. The groups were 37 patients each, which is a good number for a PRCT with 2-year follow-up, and at 2 years, 27% treated operatively had sustained recurrent dislocation versus 43 in the non-operative group. But there was no difference in objective or subjective knee function. And the other thing you have to ask yourself is if this is the right procedure for treatment of instability. Perhaps if it was done with more conventional MPFL techniques, we would have seen a lower redislocation rate. If we look at the data in adults, what we find is, again, a similar sort of pattern where there seems to be slightly less redislocation with surgery, but scores, although they might be better initially with surgery, long-term there's no difference with non-operative management. Sub-analysis of children of various studies has shown that you get greater benefit from surgery if you're younger. The most recent meta-analysis points completely the other way, which tells us that in adults, it's actually better to treat them surgically. But again, if you look at the details of the procedures, these are all things that most people do not do currently for recurrent or even first-time patellar dislocation. This slide, just look to the right at the graph, you can see here, this looks at follow-up in the short term, which is the upper set of points, and in the long term, more than 5 years in the lower set of points. And basically, this is comparing operative with non-operative management. So the further over to the left, the more it benefits surgery. The further over to the right, the more it benefits non-operative treatment. And you can see for functional outcomes, again, we're not seeing a benefit with surgery. So in summary, surgery is likely to reduce redislocation rates, but it's not yet proven in high-level studies. And functional outcomes are similar long-term, but small. There's a small difference in the short term. But not a lot of this data is relevant to some of the techniques that we're using at the moment. So for the time being, first-time dislocations, unless there is an osteochondral injury, should be treated non-operatively. But we've also got to bear in mind that surgery can have complications, particularly if there is chondral damage, you can overload that medial facet, which may be why there's a link with osteoarthritis. And if a patient comes with a first-time dislocation, a rehabilitated knee is always going to do better than one that's stiff, swollen, painful with an effusion. And in a lot of patients, for reasons we've discussed, MPFL alone is likely to be inadequate, and the risk factors are the things that really guide you as to whether recurrence will occur. But if we decide we're not going to operate, what should non-surgical care include? Should we get the patient's weight bearing after a first-time dislocation? Should we cast them, brace them, tape the patella? What form of exercises should we do? There isn't actually the evidence as to the best way to do this. So for me, if there is a hemarthrosis, or from the history and examination, I think there are risk factors for recurrent instability, I'll do an MRI acutely after x-rays. I will immobilize for a short period of time to allow comfort, and I'll use an orthosis that allows movement. I will weight bear as tolerated, and the first person I'll be contacted is my physiotherapy colleagues to see the patient and get going. And they will promote healing of the tissues while maintaining movement, but focusing not just on the knee, And one thing they don't like in our hospital is the mention of VMO exercises on a referral form, because it's not just about the VMO. You've got to work at the trunk, you've got to work at the proximal and distal segments above and below the knee, gradually build up strength and loading, and then go on to developing more lower risk movement patterns, ensuring good control and advising patients with regards to what sport they're doing, because certain sports will have an increased risk of developing recurrent patellar dislocation. The answer may be coming. So there is a study that's been set up at the Hospital for Special Surgery in the US that's a prospective randomized controlled trial that hopes to enroll 240 patients. This will compare MPFL reconstruction with non-operative management with functional and radiological outcomes. So we should get there soon. So in summary, treat first-time dislocations non-operatively, but look for chondral injury because that gives bad outcomes, and a hemarthrosis is a good sign of that. Acute surgery for first-time dislocations at the moment is not supported in kids, but I don't think this will always be the case. And probably the way going forward is going to be risk stratifying our patients with contemporary surgery. Thank you very much.
Okay, thank you very much. There's lots of questions coming for this one. A question from Mr. Adjued. In the case of instability with acute large OCD, do you stabilize at the same time as repair the OCD? Or do you prefer to stage the stabilization post-OCD repair and prehab?
So it doesn't surprise me Mr. Adjued is asking the million-dollar question. My answer to that is that I don't know. And there are times more recently when I thought, why am I not doing the MPFL at the same time as doing the osteochondral repair? And it all comes down to risks, I suppose. If someone has an osteochondral injury, the chances of redislocation is quite high, but you've got to balance that with your rehab for the chondral problem and also doing a ligament reconstruction in someone who's going to be stiff, swollen, and very sore. So for me, a lot of the chondral injuries that I see, I will treat first. I will get the patient strong, rehabilitated, fit, and then do at a later stage the MPFL reconstruction.
Okay, fantastic. Quite a few people have asked whether you order MRI scans for first-time dislocators, and perhaps when is the best time to perform that?
Yes, so it depends what I see when I examine and take a history from the patient. So bear in mind that if there are no real significant risk factors, and there are probably very few cases where someone's had a patellar dislocation because the force was high, there's nearly always something else that's predisposed them, but some patients don't require surgery. If I'm seeing someone that's had a history of occasional giving way, for example, before the actual dislocation, if it was minimal trauma, if I don't treat them, if I don't MRI them, I'm going to be doing it later down the line in all likelihoods. But in particular, you must pick up the chondral injuries because those are the things that will cause osteoarthritis later on. And those are the things that are better treated acutely.
Okay, fantastic. I think perhaps from time's sake, we better move on to the final third section.
Okay. So what I'm going to do is I'm going to show you two clinical cases, and we're just going to look at them briefly, and then I'd like you to vote. Now, they are slightly complicated. In retrospect, should have put something a bit more straightforward, but let's go for the big stuff. So this is a 14-year-old girl who's been referred from another hospital where she's presented with a fixed dislocation of the patella, which was reduced under anaesthetic, but has redislocated again. She's overweight, skeletally mature, and her MRI shows that the patella is sitting all the way over there. Now, she doesn't have obvious patellar ulcer, and when you measure her TTG, it's normal, and you can just bring the patella to the midline of the knee in extension. For any degree of flexion, it's dislocating. So what treatment would you offer? Would you treat non-operatively, MPFL reconstruction with or without a lateral release? Would you do something more aggressive and rotate the quads as well as do a medial reconstruction? Or would you do something to move the tibial tubercle as well as an MPFL? So have a go, even if you're not a surgeon, just have a guess at what you think you would do.
Okay, so the answer just coming through for that one. Those four options are non-operative management, MPFL reconstruction plus or minus lateral release, quadriceps plasty plus lateral release plus medial reconstruction, MPFL plus lateral release and tibial tubercle osteotomy. So we're up to about 60%. I'll just give it a few more seconds and then I'll share that. Okay, so we've just about hit 70% and I will then share those results. So you can see 29% went for non-operative management, 36% went for MPFL reconstruction plus or minus lateral release. That's the highest score that people went for. 13% went for quadriceps plasty with lateral release and medial reconstruction. And then 23% went for MPFL plus lateral release and tibial tubercle osteotomy.
Okay, excellent. Now I'm going to show you one more case. Again, I know it's not as much detail as you would normally have when you're seeing your patients, but bear in mind we're on Zoom. So the next case, this is a 15-year-old boy who's previously had a procedure for patellar instability, which hasn't worked. He's actually got bilateral frequent dislocations happening pretty much almost on a weekly basis. This is his MRI scan. You can actually see on the right where the patellar tendon has been flipped, the 50% of it, which is the technique used for the Rugaultweight, but you can see the trochlear is completely flat. And also the picture to the left, and this is a good sign to pick up when you're looking at MRIs, on the axial sections. If you're seeing the patella at the thickest part of the cartilage and the trochlear is not there, that tells you the patella is sitting too high or too low, normally too high. So when you look at this kid, you've examined his rotational profile and you've picked up he's got quite significant external tibial torsion, which is confirmed by CT. So if we look all together, he has previous failed surgery, significant external tibial torsion, abnormal TTTG, he's got patella alta and trochlear dysplasia. Those are your 5 options for treatment. What would you consider doing?
Okay, so just pop those up. So those 5 options again: trochleoplasty, MPFL reconstruction, MPFL and tibial tubercle osteotomy, derotation and MPFL reconstruction, derotation, tibial tubercle osteotomy and MPFL reconstruction. So we've got about 50% of people have voted.
Go on, guys, have a go. We can't see you.
It is anonymous, so we can't trace back your answer. We're nearly at 70%. Okay, so we'll stop it there at 70 and then share those results. So you can see that 9% went for trochleoplasty, 2% went for MPFL reconstruction, 18% went for MPFL and tibial tubercle osteotomy, 26% went for derotation and MPFL reconstruction, and then 45% went for a derotation, tibial tubercle osteotomy and MPFL reconstruction.
Good. Okay, well, that's interesting. What we're going to do is I'm going to give you the next talk, and then we're going to come back to that and see if I have hopefully changed your minds about what you want to do. So the final thing I'm going to talk about is the surgical management. And I know there's a lot of therapists in the audience, which is fantastic. But some of this may not be relevant. You might not think it's relevant to you, but it's always sensible to know what the options are and what you should be looking for. So surgical management, what I'm going to do is, it's impossible to cover this topic in like a 12-minute talk, but I'm going to give you an overview of how I consider it. And we're going to look at the full spectrum of patellar instability from recurrence to the more severe forms. And I'm going to go through with you my approach to treating torsional problems, patella alta, and the abnormal TTG in kids who are still growing. So you can think of it like this. When you see a child with patellofemoral instability, I ask myself, do I think an MPFL reconstruction will help them with their symptoms if they've failed non-operative treatment? And in order to do that, I will need to work out if they do have abnormalities of the parameters we've been talking about. So if I don't think an MPFL is going to work as an isolated procedure, I ask myself, what do I need to do to get the balance right? And how I do that is going to depend on the age of the patient and their skeletal maturity. But what I won't do is use an MPFL to correct other abnormalities, because those will fail. And with regards to MPFL reconstruction, there are a few pearls to always remember when you're considering surgery. You must try and ensure isometry if you can. Don't over-tension the ligament. That's not going to help. It's going to increase pain. And also fixation in the patella. Avoid breaching the lateral cortex of the patella. In the past, when MPFL was first really introduced, people were drilling all the way across and it led to patella fracture, which is a major complication. Tension on the femoral side, it's easier and it works better. And always scope the patient to look for chondral defects. And typically, what you must not do is damage the physis in the femur, because it's pretty close to where you need to be, as you can see in the pictures to the other side. So if you're worried about the physis, then you're being sensible. But the important thing to remember is that most cases, the MPFL attachment, if we talk about Schottle's point, is distal to the physis, and it's actually closest to the physis in kids who are approaching skeletal maturity as opposed to the younger children. This has been proved in both cadaveric studies and also in MRI studies. And remember, this relationship of where the MPFL isometric point is varies with growth. You can also consider non-osseous techniques such as using tenodeses or using other pulleys, so you're not considering any bony tunnels in the physis. But MPFL is not the whole of the story. The complexity of the medial structures of the knee is actually quite significant, and we're understanding this better as time goes by. As you can see from this specimen here, although the MPFL is the main constraint to lateral translation of the patella in terms of the soft tissues, there are other ligaments, particularly the distal patella constraints, including the medial patellatibial ligament and the patellomeniscal ligament, which you can see here. Also, the VMO plays an important part in stability, as does the fat pad, and really we should term all of these structures the medial patellofemoral complex. And this better understanding is leading to an exciting evolution in treatment. You can combine reconstruction of these ligaments, and this may actually allow us to avoid doing any bony work or affecting possible growth disturbance by dealing with children that have bony abnormalities like trochlear dysplasia, like a lateralized TTTG, by giving more constraint to the knee, although at the moment there's limited evidence on the success. But I will point you to the MQTFL. So this is actually part of the MPFL. This picture is a cadaveric specimen with a kneecap turned over. So some fibers of the MPFL actually will insert into the vastus medialis and to the intermedius. So there's a dynamic element to it. And people have reconstructed the MQTFL with reasonable outcomes. And you can combine it with the MPFL reconstruction. The below article from Min Kocher was a very significantly affected cohort of patients with instability, and the outcomes are actually very good. But also, if you do a quads MPFL and you do a turn down, this almost reconstructs part of the dynamic aspect of the MPFL. This boy is actually just 2 weeks post MPFL reconstruction with quads. And you can see that he's straight leg raising with a minimal lag, considering he's only a few weeks post-surgery. But what do you do if the TTG is abnormal or the patella sits high in kids who are still growing? In adults, you'd consider a fulcus osteotomy to distalize and medialize. But in kids, if you do a fulcus, you will cause an anterior growth arrest and lead to deformity. But you can do this in kids. What TTG is the right number? The figure for 20 millimeters is quoted from Dejour's originally work at more than 20 millimeters, but in kids, they're smaller, and the TTG will be different according to the age, and a tall adolescent will have a different TTG to that of a shorter one. So for me, 20 millimeters is very abnormal in children, and probably over 15 millimeters, depending on the age, is also going to be abnormal. And when I will treat that will depend on other features and other abnormalities in terms of the way the patella tracks. There is a ratio described by which you can assess according to the age by the size of the femur. Now, medializing the patella tendon is well described, and the way that this is described is with this technique called the Grammont procedure, where what you do is you lift the whole patella tendon off the tibial tuberosity, just leaving it attached to the distal periosteum. Here's a case example for you, a child who's had guided growth where I've corrected her valgus, who's got a patella that sits over with a lateralized extensor mechanism. The picture to the right, albeit taken with an arthroscope, shows you me peeling the patella tendon off the tibial tuberosity, leaving it just attached distally. And you can see here the tibial tuberosity with the cartilage intact where it's been taken off. That's then sutured, although the original description was to leave it loose and get the patient mobilizing, although it was at that stage being performed as an isolated procedure. Here we combine it with an MPFL reconstruction. That's the X-ray at 2 years post-operatively, once the patient has finished growing. Further case of a failed MPFL reconstruction in a child. 1 year follow-up following Grammont procedure combined with an MPFL reconstruction. No growth disturbance, functionally doing well in terms of outcome scores. But what about the Roux-Goldthwaite procedure? So we were all brought up with this procedure in paediatric orthopedics. These are the results actually looking at patients at Sheffield who had this done historically at an average of 8 years post-surgery. We can see in red that the problems with instability or pain post-op was about half of the patients and 30% needed more surgery. For me, the Roux-Goldthwaite doesn't correct the TTTG. It doesn't correct patella alta. What it does do is almost form a non-anatomical MPTL reconstruction. If the kid's skeletally mature, you can do a tibial tubercle osteotomy, which works well. And how you do that depends on your choice, bearing in mind the Fulkerson procedure allows you to anteriorize as well as medialize the patella. You can distalize as well if there is patella alta, but my tips for this really is once you've translated the osteotomy, check the patella tracking and fix with a device of your choice. I use 6.5mm cannulated screws, which some might think a bit too excessive. You must be careful with the Fulkersons because you're dissecting down the lateral aspect of the tibia, so the peroneal nerve's at risk. And when you're putting your screws in, you risk the vasculature at the back of the knee. I always combine a Fulkerson with an MPFL reconstruction. I'll do the MPFL once I've corrected the alignment of the extensor mechanism. The one thing that you can't do well in kids is anteriorize, which you can do with a Fulkerson. Remember, Fulkerson's original description of his procedure was not for instability, it was for osteoarthritis. But you can, by medializing, you can increase the load in the medial patella with the Fulkerson procedure. But it's actually something that will help if you have chondral defects laterally and in the central aspect of the patella. And although we're not great at treating patellofemoral cartilage defects, this is something you should try and alter the natural history of osteoarthritis by whatever technique you feel is necessary. Beware of over-medializing with a Fulkerson or with any transfer of the patellar tendon. And if you do this, you can lead the patient to suffer from medial dislocations. Where this happens, you either revise your osteotomy, or as in this case, we've revised by doing a lateral patellofemoral ligament. So if we move quickly on to torsion, what torsion should you treat? Now, this is really, for me, the most controversial area with regards to patellofemoral instability. We have normal values, but these values vary with population and your ethnic origin. But one thing we know is that torsion alters the pull of the quads, and that will then lead to increased loading over the lateral aspect of the patella. And if you look at a patella in cross-section, the lateral facet is always thicker, simply because we always have a slight valgus in terms of Q angle, in terms of the average population. And remember the basic biomechanics of the way the tibiofemoral joint moves. The tibia internally rotates when you flex your knee, which reduces the Q angle, but when you extend, it goes the opposite way. So that first 20 degrees of knee flexion, the lateral trochlea should catch your patella, which is why patients with dysplasia have more problems with instability. So increased femoral anteversion will cause this problem, and it will also increase the contact pressures of the lateral facet and strain over the medial structures. And when you have this in combination with problems around the knee, you can tell that person is going to struggle and not benefit from straightforward surgery. Again, with tibial external torsion, it's the same problem. And when you combine external torsion of the tibia with internal torsion of the femur, that leads to miserable malalignment, which is a considerable problem for some patients. For me, external tibial torsion should be corrected with a supramalleolar osteotomy. Basically, you need to alter the torsional problem between the joint below and the joint above, and these heal pretty quickly. They're easy to do. And the only concerns really are the posterior tibial nerve, and also making sure your osteotomy is done correctly so you don't translate too much. Metalwork often needs to be removed. I have combined MPFL reconstruction with tibial derotation. Now we have very good quality plates, which we can do minimally invasively. They heal pretty quickly in this way, and it doesn't massively affect the rehabilitation in the initial stages after doing your MPFL reconstruction. So I'm going to finish by talking about the really difficult ones, which are the congenital and the habitual patella dislocators. When we talk about habitual dislocation, bear in mind this isn't something the patients have control over. Basically, it means a kneecap that will dislocate in flexion. A congenital dislocation is one where someone's born with it and it's fixed. and they present at slightly different ages. Habitual tends to present in toddlers and above, whereas congenital presents at a younger age. There are a lot of diseases that can be associated with patellar problems. The commonest is Down syndrome and also Larsen syndrome. You can see also where there's a neurological imbalance, such as in cerebral palsy. With these knees, the quads tends to be mal-rotated, and the patella also inserts quite laterally with a patella that's not normal in shape. And there can be other problems with the knee joint as well. Often the medial capsule is really thin and there's a torsional problem, but the main problem is due to tightness of the lateral structures. These kids will often have quite significant extensor lag and a fixed flexion. And for the habitual patients, the way to assess them is you hold the patella in the knee, in the midline, and you ask them to flex, and they can't do it, which tells you that there is a problem there. The primary pathology in these cases is in the quads, and what you find is there's lots of tight bands that fix your iliotibial bands to your extensor mechanism, as well as it being rotated laterally. And if you don't correct this, it's going to lead to failure of the surgery. So look at this example. This is a very young child, 7 years of age. You can see the patella tendon is all the way over to the side on the MRI axial to the right, and on the left you can see where the tibial, the patella tendon is inserting very laterally on the tibia. You can see the patella marked out with dots how laterally over it sits, and here we're taking off, we're doing an extensive lateral release, and we're also releasing the vastus from the iliotibial band and lifting it off the intramuscular septum, which is what you can see at the bottom there, and combining that with a distal realignment with a Grammont procedure, and the patella then sits centrally. So in summary, with treatment, we'll come back to what we said at the beginning. I ask myself if an MPFL will work, and I base that based on if there is a torsional problem, valgus malalignment, trochlear dysplasia, or problems with the TTG or patella alta. How I get that right depends on what those problems are and also on the patient's age. But what I won't do is an MPFL to pull the patella over, because I know that will fail. Thank you very much.
Fantastic, extremely in depth there. So there's lots and lots of questions. They're all quite long, so bear with me a second. So there's a question. You've talked a little bit about your techniques for avoiding the growth plates, avoiding the physis. But when deciding whether the physis is fused in a bony procedure, for example, the tibial-tuberosity distal physis, what's the best way that you use to determine closure of that growth plate?
Plain X-ray.
Right.
There are some people that will do a Fulkerson's on the cusp of skeletal maturity, but then how do you know when the growth is going to be finished or not? You can do a bone age, for example. That will give you a guide if you're planning for the future, if you're willing to wait till the patient's skeletally mature. I often see kids that have been told to come back when they're finished growing, and when they're miserable and they're dislocating their knees and they're damaging their cartilage, sometimes you've got to think, if you've got to correct the problem. So I have done Grammonts. I've never regretted doing it. What I have regretted doing is an isolated MPFL in people with other problems with the knee joint. I've never regretted correcting the torsional problem or realigning the quads mechanism.
Okay. And along similar lines, at what age would you consider osteotomy and derotation for the miserable malalignment patients if they've undergone physiotherapy rehab and have sort of had little change to functional pain?
There's no limit really if you're going to correct external tibial torsion. The one thing is the natural history of torsional problems in kids. So we know that rotation continues to change throughout growth, and for tibial torsion, external torsion will correct up until probably about 9 or 10 years of age. Once you get to that age, you will see further correction, but it's going to be very limited. But it really depends how bad the torsion is. Sometimes you'll see kids with 50 degrees of external tibial torsion who are age 6 or 7. In those children, you would correct by 20 degrees if they were having patellofemoral instability. But we're just talking about correction with instability here, as opposed to miserable malalignment. For miserable malalignment, it's a little bit more difficult, because those I would wait until adolescence at least before I did anything. Then you've got the question, do you correct tibias first, femurs first? Do you do one side then the other side? And that's why rotational profile is important. So if you've got someone with just miserable malalignment, you can do just bilateral tibial derotation osteotomies distally or proximally if you want. When you do that, initially they'll walk with an internal foot progression angle, which can cause them some concern. What will happen though is if they've got enough opposite movement, so if they've got some external rotation of their hip and enough of it, they will automatically correct their foot progression angle. So the difference there is they've still got femoral anteversion, but you've corrected the mismatch between the internal femoral torsion and the external tibial torsion, which often helps with the pain.
And along similar lines, what degree of femoral anteversion and external tibial torsion is an indication for derotation osteotomy in your practice?
Yeah, these are great questions because I can't answer them because I don't know the figure. And I think really you have to take it in terms of what else is wrong with the knee. So for me, a figure of external tibial torsion is over 40. With someone with patellofemoral instability, I will correct that. Not in every case. Again, it depends on the TTGG, it depends on ligamentous laxity, it depends on the patient, it also depends on whether there's trochlear dysplasia. I very rarely do femoral derotations, simply because if I do them, it's for miserable malalignment, and in isolation, I haven't found it's needed or it's been helpful. For me, it's the tibial torsion that's the main problem, and I'll correct that. So tibial torsion, probably over 40 is where you start thinking about surgery. I'm not sure if that will get lower the more cases that I do.
Are there any sort of, looking at the patient as a whole, but are there any specific syndromes that would lead you to choose surgery earlier, perhaps Prader-Willi or Downs or things along that spectrum?
Yeah, the Downs, the kids with Downs, they do struggle. And I think part of the problem is that because of their issues with communication, they can't tell us exactly what they're suffering from. So you tend to only get these kids when they're really struggling with severe instability. And the natural history is if they're dislocating when they're younger, once they get ambulatory and they're independently mobile, if it's still happening, it will just get worse and they'll end up with a habitual dislocation, then a fixed dislocation. Then it becomes a difficult problem to fix. But with Downs kids, it depends a lot on their general health. A lot of them will have cardiovascular problems. They'll have severe ligamentous laxity as well. So that's also going to cause problems. But with those children, an isolated MPFL is highly likely to fail if they've got a lot of lateralization of the extensor mechanism. And you always underestimate the amount of lateral tightness they've got. So they often need quite an extensive lateral release to get things aligned.
Okay, fantastic. We have still got a lot of questions, but I think for now, I'll perhaps pass them on to you afterwards, if that's okay, Mr. Nicolaou. There's still quite a few we couldn't get through, but it just really remains to say thank you very much for 3 fantastic talks, really covering a real range of topics around the patellofemoral disorders within pediatric patients. A really interesting session. Thank you very much. So yes, I will pass on those questions to you if that's okay after this session, and we'll endeavour to answer as many of those as we can. So thank you very much. Just really remains to talk about the next session. So next week we have a very interesting and unusual session with Amit Kumar about knee pain and what else should you consider. So he is a consultant orthopaedic and sarcoma surgeon. So a very interesting and again, a different talk to give you a variety of different topics and things to look at. So the link to that is in the chat. Thank you very much for joining us tonight. And again, thank you very much to Mr. Nick Nicolaou for his fantastic talk tonight. And we will see you next week.